at National Hospital, Lahore. So I guess everybody's cholesterol is very low at this point, and we don't want it to get any further lower: sugar, blood pressure, cholesterol, everything, and we are talking about all those topics. So I'll be talking about, for the most part, the newer guidelines, how are they different from that, and what the treatment recommendations are, and some safety recommendation. So I would kind of skip that. All of us know that cholesterol causes death by increasing cardiovascular mortality. The new paradigm that has changed is that we have now moderate intensity and high intensity statin therapy and low intensity statin therapy, and that goes by the risk factor that you have. And Dr. Junaid Zafar very kindly alluded to it. He showed you the ASCVD risk calculator. So that is the key at this point in time, to know your risk, what your risk is, and then your therapy should be modified to that. And once you have it, then after that, you check your LDL and see if you are at goal or not. But now we don't have a specific goal. Now they say you have to decrease it by a certain percentage. If you're a high risk, you want it to be decreased by 50% of where you start. And they have identified 4 groups that all of us should take home with us, that how we're going to treat. So these are the patients with clinical atherosclerotic cardiovascular disease. So who are these? These are the patients who have an MI, who have a stent, who have a bypass surgery, or who has a major epicardial coronary artery which is greater than 50% stenosed. These are the patients who have history of stroke. Then next category is LDL more than 190. So irrespective of your age or risk factor, that falls into a high risk category. And then subsequently, you have patients who are, vast majority of the patients that we see falls between 40 to 75 with an LDL of 70 to 189, and they don't have any risk factors, and you calculate the score for them. Or you have the same risk patients, but they have atherosclerotic disease or diabetes. This is a very good flow sheet, and this is from actually fairly about 10 years ago by ACC-AHA, and I would like everybody to look at it, and this is kind of important. So you have somebody who have atherosclerotic cardiovascular disease, they automatically fall into high statin intensity group. If you have somebody who does not have this and the LDL is more than 190, they automatically fall into high intensity statin group. Now, if not, then you are a diabetic. If you are a diabetic, you automatically fall into moderate intensity group. But if you are a diabetic with a risk of more than 7.5% in 10 years, then you fall into high risk category. So 4 things to remember: anybody who has atherosclerotic cardiovascular disease, LDL more than 190, or diabetic more than 7.5% in 10 years would get high intensity statin therapy. Another thing to remember, all diabetics would fall into moderate intensity statin therapy. Now, how do you get that 7.5% number? This is the calculator. How do you calculate it? You get an app on your phone. I think if all of you can just go and put in your app store ASCVD or Samsung, and you will get this app. This app is not very, I would say, bulletproof, because it does not have family history. It does not have a lot of other factors in it. It's something very basic, but this is what we have, and this is what we are using at this point in time. So I was mentioning about moderate and high risk statin therapy. What are the moderate and high risk? So high risk are basically Atorva 40 to 80 and Rezuva 20 to 40. And low risk are Petava 1, Prava and Lova, and Simva is not available anymore. And moderate are rest of them. So for us to remember, Atorva and Rezuva are very easily available in Pakistan, and all the brands are available there. So if you have an Atorva 40 or a Rezuva 20, that would classify as a high risk therapy. I would say low risk therapy would be somebody, Petava, which is easily available, 1 milligram Petalo. Genix has sponsored this lecture also. Or in the medium dose therapy, again, you can have Atorva 20 or a Rezuva 10 or a Petava 2 to 4 milligram also. That is available. That will qualify as a moderate risk therapy. So statin safety, you just have to check the LFTs, make sure patient doesn't get any myalgias. If the patient has impaired hepatic function, age more than 75, or ALT more than 3 times the normal, or history of hemorrhagic stroke, you may have to adjust the dose. So the baseline is to check the LFTs every so often. 3 to 6 months is recommended. And if your 2 consecutive LDLs are less than 40 and you are in a high risk group, then you can consider decreasing the dose. LDL should be checked every 3 to 12 months till we reach the goal. And if the goal is, if the patient has statin intolerance, then you can consider redosing at a lower dose, or re-challenging with some different forms of a statin also. High-risk individual, as I said, greater than 50% LDL reduction is the goal. Few words about a zeta maybe. I think it's a good choice to have if patient is statin intolerant. A lot of patients in our Pakistan population, once you prescribe them Rosuva 20 or 40, they do get statin myalgias. So adding an azita maybe to a moderate risk statin goes a long way. That you can give them like 10, 20 of Atorva, 10 of Rosuva and add an azita, or 2 of Pitava and add an azita to it. Bile acid sequestrants we don't have available here. Velcol is the name of the drug available outside. PCSK9 inhibitors, very exciting times but extremely expensive. I have a slide for that. I don't know if you'll have time to go over that. Again, think about sending the patient to a cardiologist or endocrinologist. Always think of homozygous hypercholesterolemia, these patients who have very high resistant LDLs or triglycerides. So now I'm going to switch gear. I think I've used only 5 minutes and I'm going to talk another just 5 minutes. And I think it's easier to discuss cases and that you'll have something to take home. So it's a very typical patient, 62-year-old, total cholesterol is 140 and systolic blood pressure is 130, HDL is 35. The patient is non-hypertensive, non-diabetic, non-smoker. Now most of us would not prescribe any statin to him. Now if you punch all these numbers in the ASCVD calculator, his 10-year risk is 9.1%. So where does he fall? He falls into moderate to high risk category. So this is what Junaid was saying, that it's very important also that we need from our medical standpoint, liability standpoint, and everything should be data driven. So I can assure you, this is most of the patients that all of us see. And even if I don't put it in the calculator, I would say, you know, it's okay. Your total cholesterol is not that bad. HDL is 35. You're not a smoker. You don't need a statin medication. But the reason his number went up was because of the 62. So the risk calculator calculated it 9.1 and he falls into moderate risk category. So which are the moderate risk category drugs? As I said, you can give him Atorva 20, you can give him Rosuva 10, or you can give him Pitava 2 to 4 milligrams. Okay, another patient. So this is 50-year-old female. Total cholesterol is 180, HDL is 50. Systolic blood pressure 130, diabetic, smoker. ASCVD 10-year risk score is automatically goes to 9.8%. So where does this falls us? So she automatically goes into high intensity therapy group. Now all diabetics automatically fall into moderate intensity group. So just keep that in mind. So diabetics are a different class of people, or anybody who has a stent, bypass, stroke, peripheral vascular disease falls into automatically high risk group. All right, so this patient needs a high intensity. High intensity, we have only 2 agents at this point, Atorva 40 or Rosuva 20 to 40, or Atorva 80 also. Again, another patient. So you have a 48-year-old female, total cholesterol is 180, HDL is 55, systolic blood pressure 130. She's diabetic, non-smoker. Risk is only 1.8%. What are you going to do? It's only 1.8% risk. This is the key. She's diabetic. So where does she fall? She falls into moderate intensity group. What are you going to give her? You're going to give her one of these several agents that we have available. You give her a Atorva 10 or 20, you give her a Rosuva 10, or give her Pitava 2 to 4. Okay, 22-year-old white male. So white male or whatever, since, you know, I worked abroad also, so these slides from before. LDL 195, normal BP. So young kid, goes to college, doesn't smoke, very active, goes to gym. LDL 195. So that's the deal clincher. You know where it puts him? Where? Here you go. High risk statin therapy. So he's only 22, but an LDL greater than 190 bought him a high risk, high intensity statin. There could be family history. So Dr. Chima is very right. So you may want to work him up for a familiar hypercholesterolemia. The best thing easier would be to ask what his dad's cholesterol is, what his mom's cholesterol is, or what siblings' cholesterol is. But yes, but the treatment, irrespective of that, this 22-year-old kid would need a high-intensity statin therapy. So the take-home message is the LDL of 190 that I'm saying. Okay, case 5. So this is a patient, 66-year-old white female, total cholesterol is 230. Systolic blood pressure 150, not taking any BP medication. Our senior colleague Dr. Shahid kind of took care of that. Non-diabetic, non-smoker. Calculated 10-year risk of 2%. So what are you going to do in this? This is a non-diabetic patient with a two-year statin, sorry about that. LDL नहीं दी हुई. आप अगर उसका रिस्क कैलकुलेटर में भी देखेंगे तो जरूरत नहीं आपको पड़ेगी. तो ये किधर फॉल करेगा? Sorry, I think we kind of missed on that. So, ये किधर fall कर रहा है patient? Statin therapy is not recommended because the score is less than 7.5% because it does not fit any of the criteria. So take home message is, what I would say is that instead of using these, I think 70 is a good number for patients who have disease. Now the new number is 50. I think what you need to do is you need to risk stratify your patient. Put them in an ASCVD calculator. And then there you go, whether you're going to prescribe him moderate or a high intensity. And subsequently you'll see that uska 50% कम हुआ है या नहीं. जैसे मैंने आपको शुरू में talk किया, I mentioned earlier that these are the 4 groups you need to look at. Patients who have a stent, stroke, peripheral vascular disease, LDL more than 190. ये आगे आप automatically उनको high risk में डाल दें, high intensity therapy में. Diabetic आ गया more than 7.5%, you put them in high intensity group. All diabetics go to moderate intensity group anyways. So I guess all of us should pull out our smartphones. I doubt there'll be any person right now who doesn't have a smartphone and get this app calculated. ESC also has a very good risk score calculating app. Problem is it has about 5 calculators. So it takes you a while which one you have to use. This is not, I would say, very comprehensive, but it's a very good, simple, quick and dirty way to calculate it. I think I can stop here at this point in time. If you want, I had a couple of slides about LP little a and PCSK9 inhibitors. LP little a is is a new thing that is not a new thing, it's been available for a while. I think if you have patients who you consider as high risk, do check on them. Or most of the labs here are available. If the number is more than 50, that will qualify them to be a high risk patient. PCSK9 inhibitors are again not very new. These are subcutaneous medication. This is a very long name, paraprotein convertase subtilsin kexin type 9 inhibitors that are available out there. Wonderful drugs, extremely expensive, currently about $6,000 a year, but they don't have any myalgias, nothing. The dose is once every 2 weeks or once a month. I have about 5 patients on them. So I'll stop here. Thank you very much for your attention.